Not a problem, thank you. My name is Banujan Balachandran. I'd like to take the opportunity to thank the SAGES Committee for giving me the opportunity to speak today. It truly is a privilege and an honor to speak in front of a distinguished audience. Furthermore, I'd also like to acknowledge the work and the efforts of all the individuals responsible for putting on a wonderful conference. I have no conflicts of interest to disclose. So symptomatic gallbladder disease is treated through surgical removal of the gallbladder. Historically, this had been done through open surgery where one large incision was made at the right flank. This was further improved upon using the MultiPort laparoscopic technology in which multiple port sites were used and this to be more minimally invasive. More recently, this was further improved upon with the introduction of the Da Vinci technology in which a single port site was used and built on some of the limitations of the laparoscopic tools within a single port site. So while there have been several studies that look at the single-site robotic cholecystectomy and its efficacy, very few have looked at perioperative and post-operative outcomes, and furthermore, even fewer have looked at them in head-to-head comparison with the gold standard, which is the MultiPort laparoscopic cholecystectomy. So our aim of our study was to investigate the safety and efficacy of single-site robotic cholecystectomy in a head-to-head manner with the MultiPort laparoscopic cholecystectomy, and we evaluated all of this through a single surgeon's experience to eliminate any operator bias within a high-volume tertiary healthcare center. So our methodology, we performed a retrospective analysis on cases between October 2011 and July 2014. The picture on the left, as you can see, is demonstrating the single-site robotic technique, and the picture on the right is showing you the MultiPort laparoscopic technique. So we were able to successfully recruit 678 patients that met our inclusion criteria. Of that, 415 patients were performed single-site robotically and 263 were MultiPort laparoscopic. Unfortunately, we did see some differences preoperatively within the two groups. We found that there was a greater percentage of male patients within the MultiPort laparoscopic group, and furthermore, we saw a slight increase in the body mass index of patients who underwent MultiPort laparoscopic surgery. Even further, we also saw differences in the incidence of patients who were diagnosed with acute cholecystitis being higher for MultiPort laparoscopic. We also saw a greater incidence of comorbidities, which included specifically coronary artery disease and COPD. Finally, we also saw patients who had already undergone prior abdominal surgery more frequently within the MultiPort laparoscopic group as opposed to the single-site robotic group. So in conclusion, the surgeon did elect to undergo laparoscopic surgery more frequently for male patients, patients with a higher BMI, and for more urgent surgeries. The only comorbidities that we were able to see that were more common within the laparoscopic group, even though the ASA classification did not show any differences between the two groups, was the incidence of COPD and coronary artery disease. So in assessing operative characteristics, we compared the total operative time between the two procedures. We found that there was no variation between the two procedures, and it was in about 90 minutes completed. When you looked at the single-site robotic group, we found the conversions, about half of them to laparoscopic and the other half to open. And again, both procedures show no differences in the rate of conversion. Within the surgeon's hands, the average console time was 57 minutes with an average docking time of 6.8 minutes. There were also no significant differences in total operative time, estimated blood loss, or conversion. This just highlights the point that the surgeon was comfortable performing both techniques. In assessing post-operative findings, we found that there were no significant differences in 30-day post-op visits to the ER, as well as mean follow-up time between the two procedures. This is despite the fact that there were more ill patients within the MultiPort laparoscopic group, and we saw a slight increase in the length of stay within the MultiPort laparoscopic group. And again, this can be ascribed to the fact that there were more ill patients within the MultiPort laparoscopic group to begin with. So then we looked at more post-operative findings. In the short term, what we found was patients reported more complaints of abdominal pain within the single-site robotic group, and they also showed a higher incidence of wound infection. This is despite the fact that there were more healthier patients within this group to begin with. And then when we assessed any long-term post-operative outcomes, most interestingly, we found a greater incidence of umbilical incisional hernias, specifically 27 cases of the 415, or about 6.5% compared to only 1.9% within the MultiPort laparoscopic group were diagnosed with umbilical incisional hernias. So to investigate this hernia incidence further, to ensure that it wasn't an artifact or anything of that nature, we looked at how many of these diagnoses have been operated on. Well, so far, 20 of the robotic and 4 of the laparoscopic, or 4.8% compared to 1.5%, have already been operated on. So the robotic technique is a newer technique. Is it possible that the surgeon's comfort level wasn't well established in that technique? Could it be possible that the 27 cases of hernias were all within the first 100 or first subset of cases? So we did a subgroup analysis, and we split the patients in the first 100, second 100, third 100, and the remaining group of patients. And we found that there was no difference right across the board. So regardless of his comfort level of the technique, the hernia incidence didn't change over time. Was it possible that BMI played a role in the incidence rates? And we looked at BMI, and there was no statistical significant difference between the two groups in terms of hernia, in terms of BMI for hernia. And then finally, we took a look at the number of the hernia cases specifically in more detail for the laparoscopic group. And what we found, of the 5 patients, 1 of them had 4 prior abdominal surgeries. This obviously means that one of those procedures could have been the reason why they resulted in the hernia. We had another patient who had a history of multiple ventral hernias to begin with. We had another case where this patient had been converted to open procedure. And finally, we had a patient who had a prior appendectomy, which was completed single-site robotically. So in essence, we only had 1 patient of the 5 within the laparoscopic group where it was highly likely that the procedure in question was the reason why they resulted in the hernia. Now, if we performed the same analysis and excluded all patients who had any form of prior abdominal surgery, whether or not it was in the umbilicus, we found once again the hernia incidence rate was higher among patients who underwent single-site robotic, which was 2.9% compared to only 0.4% in the multiport laparoscopic group. This once again, leaves a very high and reasonable probability that the incisional hernias that resulted in these patients were a direct consequence of the procedure of choice for treating their symptomatic gallbladder disease. In looking at major limitations, of course, there were a few because of the fact that this study was non-randomized and retrospective in nature. The conclusions we can make now is that although more healthier patients underwent single-site robotic cholecystectomy, the incidence of abdominal pain, wound infections, and incisional hernia was significantly greater in this arm. And it appears at present that the multiport laparoscopic platform should remain the gold standard for treating symptomatic gallbladder disease. Moving forward, we would like to see a large prospective randomized study looking at outcomes between the 2 platforms to see if they can confirm our findings. I'd like to acknowledge the entire team at Advocate Lutheran General Hospital in Chicago, Illinois. And I'd like to thank you for your time. I'd be happy to take questions now. Thank you.